What was sort of the goal of you and your co-authors in terms of, when you were putting this together and getting it ready to go to share with your colleagues? What was the driving force behind that?
So sure. So this the idea for the paper arose from a conversation which was during a teleconference for the Practice Management Committee of the American Headache Society, which occurred on March 18th. And we were talking about all of the challenges we were all experiencing and how these undoubtedly translated to challenges for all of our colleagues in headache medicine and their patients. And we had lots of concerns and lots of ideas about how we might be able to manage them more effectively. And so the idea of putting this into a guidance document really gelled very quickly. And Christina Sperka from University of Pennsylvania, she really took the lead on writing it and putting it together. And we give huge credit also to Tom Ward, the editor-in-chief of Headache, and Jason Roberts, who is really the publisher, and being able to move this along very, very rapidly, so that 12 days later it was actually published online. And I think that the guidance has come timely enough so that it's helpful for our colleagues who really are looking at this. And largely it's kind of a compendium of the things that we generally do, both on-label and off-label, to try to help our patients, particularly with the view that some of the things that we lean on doing, like these procedures, or inpatient stays for people who really have reached a kind of that threshold where they need that kind of care, that's really not acceptable, an available or accepted type of practice right now. So so we kind of group thought it and provided what we thought were the best available issues. And some of them were kind of very practical. Some of them were really specific to the circumstance. So for example, it's well established, this is only a few months old, but well established that headache is often a very early symptom of COVID. And whether or not it's the earliest symptom of COVID, I haven't heard, but it would not surprise me if that's true. And that, combined with perhaps some other subtle symptoms like anosmia, maybe those are things that that we should, as headache physicians specifically, should be attuned to, that when somebody has a new headache disorder in the last few months, that really thinking about COVID is really not inappropriate. It's a really reasonable, appropriate thing to do. The other issue is that there are some classes of medications which have been raised as possibly contraindications in the setting of COVID. Specifically, NSAIDs have been raised, and angiotensin converting enzyme inhibitors and angiotensin receptor blocking agents all have come up as possibly a concern. And so we've kept on top of that, and the guidance from the World Health Organization as well as from the FDA are that there really is not credible evidence-based reasons to avoid these medications at this point. It's not that this isn't a fluid situation. It's possible that either those medications or others we might learn should be avoided. But at the time that we posted this on March 30th, and really since this, over the past week and a half since then, there really have not been any reports further that suggest that that's something that that should be avoided. We, also again in terms of the insurance carriers, it is really important to for us to be sensitive to the fact that a huge number of people are now out of work, that co-pays are a much bigger burden for many people now than they had been, that chronic migraine is much more strongly comorbid with people who are in the lowest economic tiers, that people who have the least advantages economically. So if there was ever a time for payers to be generous, and actually pharmaceutical companies potentially to lower the costs, now would really be the generous time to show that. So these were issues that came up. Another issue is that that adolescents are, rarely not responsive to the same headache medicines that adults are. So if a medication is FDA approved for adults, but not yet approved, or not approved anyway, for adolescents, this would be another time for payers, whether it would be CMS or private payers, to cover this for adolescents. I mean, we're in a realm where the president is actively promoting off-label use of hydroxychloroquine. Surely the government in the setting of CMS can approve the off-label use of a medication which could be very effective for our adolescent patients who have disabling chronic migraine as well. There was a new event which occurred actually since we posted the article, which is that CMS provided some guidance specifically about loosening some of the regulations and restrictions for certain types of therapies. And one of them was that there was kind of a maximum granting of physicians to be able to provide prescriptions for medical gases. This has a big impact for our patients who have cluster headache. So cluster headache is extraordinarily responsive in most patients, individual attacks with high flow oxygen. And CMS has really been unable or unwilling to cover this for Medicare and Medicaid beneficiaries. And then private payers, many of them will take their cue from Medicare and Medicaid and also refuse to cover it as well. So this guidance now will provide the ability for our cluster headache patients to receive oxygen therapy, which is really a huge benefit. And we're very much hoping that that will be a durable change, that we won't go back to the time when people would have to endure excruciating pain when oxygen could relieve it and relieve it quickly and safely. I would say one area where it's personally been very helpful to engage on this issue is with the authorities within Vermont Medicaid. So for, as with every other state, there's a drug utilization review board, which helps to provide the policy determinations for how different therapies can be prescribed for Medicaid beneficiaries. And again, I like to think maybe this is something that's Vermont related, but we have a very responsive and I think patient interested utilization review board, and I've had an extensive email conversation with the board, and they've been very responsive at trying to ensure that these transitions, for instance, from Botox to CGRP medications, can be done relatively seamlessly, and that other therapies are going to be looked at. In particular, since really about 6 months ago, there are 3 new acute medications with new classes for migraine, CGRP antagonists and also 5-HT1F receptor agonist medications. And our drug utilization review board will be reviewing them in a couple of months, and it'll, of course, likely be by Skype, but I'm hoping and expecting to be able to provide some testimony at that hearing to discuss what the advantages for Vermonters who have disabling migraine might gain from these medications. And it actually is a great advocacy opportunity in all 50 states for headache physicians to engage with their drug utilization review board to, again, try to ensure that these medications are used wisely and helpfully for our patients who really have these specific needs.